Like many of you, you're either here because this is part of the professional work that you do, or because you have a personal story or a connection to this topic. I just happen to be, both. I am not a researcher. My role at ISPU is to take the research that we do and then somehow find a way to make sure that all of us understand it and find a way to incorporate it into the work that we do on a daily basis. As someone who's not a researcher, that means I need to understand what the research is talking and how to translate it to the work that you all are doing. ISPU's goal and vision is to make the equitable work or the amazing work that every single person in this room and outside of this room is informed and based on facts. And this is so important, especially in the moment that we live in, as we know there is so many misinformation and so many misrepresentation of American Muslims and Arab Americans. And so it just makes it that much more important for us to make sure that the work is empowered by facts and backed by research. Because as we are learning the very hard way that people will find an exception to the individual story, but it's really hard to argue with the data and the research. And so that's what ISPU's vision is to ensure that we envision in America where one day, hopefully, American Muslims or Muslims are thriving and equal. That we move from the space where we're always in defense and trying to question if we belong, but we are thriving and equal and envision in a place where we're productive more than we already are. And as I said, our mission is to provide objective research and education for anyone who's making decisions about American Muslims, whether that's American Muslims themselves or people outside of the Muslim community. ISPU's research focuses on the community internally, but also on the community externally. What that means is our research includes everything from Islamic schools, family, divorce, marriages, drug abuse, disability, all of these things that any individual in this room cares about because they're part of your personal experience or your community's experience. But we're also part of a larger society that, sometimes we belong and sometimes we don't. So our research focuses externally on the relationship between American Muslims and the larger society that we're a part of. It looks at civic engagement. It looks at discrimination and Islamophobia. It looks at pluralism as a whole, and it looks at providing a space where thought leadership is part of the process and part of the work that we do. ISPU was born here in Michigan by an amazing group of visionary thinkers more than 22 years ago when they, just like the moment right now, saw a lot of people speaking on behalf of American Muslims and pretending to be experts on who we are, but not truly represent our community based on facts and based on research. So they came together and envisioned this amazing institution. And yes, this might sound very biased because I work here, but truly for anyone who has been doing work in the American Muslim community will understand the impact of ISPU's research, both locally and nationally. Born in Michigan, but a nationwide organization, very small but mighty all-women team. Actually, we do have one guy, but he's in Columbia. We have many affiliated scholars across the country and people that we work with and experts outside of our organization. The last piece is very important. We're a nonpartisan, non-religious, meaning we don't do theology work. We don't research Islam. We don't speak on behalf of Islam. We talk about American Muslims as people and their experiences as people, no matter what their religiosity, what their sects, what any of that, okay? And one last piece that's not here, that's very unique and not common in the nonprofit space, especially in the Muslim space. None of our founders or founding board members are part of our board currently. That speaks to the health of the organization, and we also have a nationally an award recognized board that's serving this institution. This is just a very small glimpse of the type of work that we do. Research that look at Islamic schools, like I mentioned, religious-based bullying, to Native American Muslims. Latino views of American Muslims, Black Christian views of American Muslims, the Muslim vote and policy priorities, and just everything in between, including our topic today, which is health equity. And one of our major projects that's been going on for more than 7 years, American Muslim Poll, which is right now being fielded, will be out in the fall, not only looks at American Muslims nationally in a representative sample, but it looks at them in connection with other faith communities. So in the same poll, you will see American Muslims, American Jews, American Christians, including Catholics, Protestants, white evangelicals, non-affiliates in the general public. You do not find that work anywhere else. You also do not find the topics that we research in that poll in the depth in the same survey with any other organization. So today's project, we're very fortunate to be supported by the Robert Wood Johnson Foundation and have our partner, the Huda Clinic, which you'll hear from Tracy in a minute. It looks at the counties here, Wayne County, Oakland County, Macomb County, and Washtenaw County. And it looks at the Muslim communities and access to healthcare in those counties. So this is literally for you all. And this is one of the unique local projects that we've done. Most of our work, as I mentioned, is nationally. Very briefly, American Muslims in the state of Michigan make up less than 3% of the population, of the state's population, but 15% of its medical doctors. Right? And so it's not only the doctors and people in the healthcare industry who are of Muslim background, but also the impact on our families, those who have disabilities, the ones who take care of elderly parents, which, we have a larger segment of the Muslim population than other faith communities. It's the youngest faith community in the nation. It's also the most ethnically diverse faith community in the nation. So I want to have that as a background for today's conversation. And this project would not have been done without the amazing team, our research team, including Dr. Iyaz Haider, who you'll hear from him in a minute, who will walk us through the research and the finding. Muhammad, who will be part of our panel, and my colleague, Era Makramallah, who is the project manager, and without her dedication and focus, this project would not have been done because it faced a lot of hiccups. And finally, our partner on the ground, as I mentioned, we do national work, but we always work with people on the ground, is Huda Clinic, which many of you are familiar with, so I'm not going to spend a lot of time introducing it. I'll leave that to Tracy, who I want to welcome Tracy Wilson, who's the executive director of the Huda Clinic, to share a little bit about her work and how this project, how this partnership came about, but also what this project will be utilized as part of Huda's Clinic mission. Tracy have been with the Huda Clinic for more than 8 years, obviously led the organization through a global pandemic, and implemented a major internship program leading more than 600 students and providers. I'm not going to do a full introduction for all of our speakers because they're amazing and we could take hours doing that. So Tracy, can you come up please and tell us how this partnership?
Assalamu alaikum. Good evening, everyone. First and foremost, I want to extend our deepest gratitude to the Institute for Social Policy and Understanding and to Dr. Haider for not only including Huda Clinic in this important research initiative, but entrusting us with a critical role from the very beginning. It's been an incredible honor for us to serve as members of the core modeling team on this project. As many of you know, Huda Clinic is no stranger to partnerships. In fact, it's foundational to everything that we do, whether that's providing care, building infrastructure, or shaping the next generation of healthcare workers. We know that when we collaborate, the community benefits. This research shines a necessary light on the unique challenges that the Arab and South Asian Muslims in Southeast Michigan face in accessing healthcare. It validates much of what we have already seen on the ground for years, and it affirms the importance of culturally competent and community-centered care. The group model building participants identified Huda Clinic as an organization that is both high in power and high in interest when it comes to addressing these disparities. That recognition is not taken lightly. It speaks to the work that we have been doing for over 20 years and the work that we know still lies ahead. So what are we doing? At Huda Clinic, we've built a training ground for future healthcare professionals who reflect the communities they will serve. The majority of our interns are from the Muslim community. Many of them have personally experienced the barriers to culturally competent care. And we're not just training them in clinical skills. We're also equipping them to be advocates, educators, and change makers. Take diabetes, for example. Type 2 diabetes is disproportionately more prevalent among the South Asian populations, which is especially prevalent to our Huda Clinic community as we service a large Bangladeshi population. Yet mainstream resources like My Plate from the American Diabetes Association or diabetic recommendations from the CDC fall short in addressing cultural dietary patterns. At Huda Clinic, we've bridged that gap. We've developed culturally specific, medically sound dietary plans for the communities whom we serve. Because it's not just about managing disease. It's about respecting identity while we're doing it. Another key insight from the research is the need for Muslim community health workers. I am proud to share that I've been working directly with my coach and Southeast Michigan Community Alliance to address this. Many of our interns will become those very community health workers, serving in the neighborhoods they understand, with the languages they speak, and with a cultural fluency that makes real connections and care possible. And finally, mental health. We all know the stigma that surrounds mental health, especially within the Muslim community. But we also know that it's time to break the silence. At Huda Clinic, we are blessed to have incredible Muslim psychiatrists who are not only leaders in their field, but they're leaders in the community as well. And beyond that, we're preparing to launch our second round of community mental health first responder training for our interns. This program is designed to give our young healthcare leaders the tools to not only serve the patients within our clinic walls, but to bring those tools into their own families, their mosques, and their neighborhoods. So what does this research mean for us? It affirms that the work that we have been doing matters. And it challenges us to keep pushing forward, to continue building partnerships with institutions like ISPU, Henry Ford Health System, Corewell Health, Michigan Medicine, Wayne State University, Michigan State University, University of Michigan, University of Detroit Mercy, the Free Charitable Clinics of Michigan. These partnerships will further empower the communities we serve and ensure that no one is left behind when it comes to health and healing. Thank you all so much for being here this evening and for your willingness to help us build a stronger and healthier community.
And just to give you an idea of how ISPU work, because we do research at the national level, many years ago, Huda Clinic was actually one of the organizations we studied as an example of things that are being done really well in the Muslim community. So Huda Clinic is one of our case studies that's viewed now nationally, and other communities could take a look at that study and kind of replicate it in their own spaces. And that many years later, they're a partner on a major study in this local community. And so that's kind of ISPU's work, both at the local and the national level. The next person I have coming up, just very briefly to talk about the importance of this project and how you can all of you use it in your daily work, is Dr. Iltfa Hamzawi. Many of you know him. Many of you know he wears way too many hats for me to list here. But for the purpose of this conversation, he's one of the visionaries behind founding ISPU, and he was a board chair for ISPU. But he's also a certified dermatologist, dividing his time between his private practice, his family. He comes from a typical Muslim family, many health professionals. He spends his time between his private practice, but also Henry Ford Hospital, where he's the co-director of the investigator-initiated research unit. Dr. Hamzawi, along with the Henry Ford dermatology team, has published over 230 peer-reviewed articles and book chapters. He's the co-editor on 2 books. Like I mentioned, he wears way too many hats for me to mention. And he was also one of the core modeling team members of the study. I know we keep repeating this word. You'll know more about it in a second. So Dr. Hamzawi, if you could please come up and share with us the significance of the study.
Assalamu alaikum, and thanks. I know Petra is always here. She's got this tremendous personality and a stature that takes the mic to a different level. It's such a pleasure to kind of sit here and just watch the way ISPU and our wonderful scholars from the school down south called Ohio State have put this project together. And I think at this moment in our society where people are wondering, is diversity really a thing? And is everybody exactly the same? And if the people in power or the people who have influence don't think that's the case, then do our differences and our similarities mean anything at all? And I would suggest to you that a study like this, which looks at the healthcare system and looks at a significant but small and growing group within the healthcare system, is actually a group that should be studied. But it's not to be studied just because of the group, because there is a shared reality that is based upon data, which is very much part of the ethos of ISPU. You can have a perspective, you can have an interpretation, you can have an influence of media, but at some point you have to have that grounded by what's actually out there on measurements. There's a scholar from the 12th century, Al-Razi, who basically defined elements of the scientific method. And the scientific method is basically if you see it, and you see it, and you see it, and then we all see it, and then we see it in Spain, we see it in India, we see it in South Carolina, we see it in Canada, and you all see the same thing within a certain range, that's true. That's truth. Different perspectives. That process, as applied to minority communities, can help all of us. I work in a disease called hidradenitis suppurativa. It's a disease that's so bad that you can't even pronounce it. It's explosive boils that occur in the groin, in the underarms, that cause horrible odor, 10 out of 10 pain, tremendous drainage, and mental health stigma that you can't imagine because it hits young people going into their 50s and 60s, from the 20s to the 50s, like a hot poker going through your groin to the point where you can't even sit down. And when I started working in this field, most people felt that it was a disease of Caucasian males with a decent number of Black Americans affected, but we didn't know how many. And we spent a lot of time researching that. We ended up finding out that 1% to 4% of the American population suffers from that, but they don't talk about it because it's such an embarrassing condition. You don't walk up to somebody and say, "Hey, how are you? I'm doing well. I have pus pouring out of my groin." Not exactly dinner table discussions. But what we found in those studies over the years was that it was so prevalent, and Black women were disproportionately impacted, but the most common individual to have this condition is a Caucasian woman. And the greatest burden of disease is actually a rural male. When we study our differences, we understand ourselves better. And it doesn't always mean we look the same. It doesn't always mean that we pray the same. What we do define the range of how we're different and how we're similar. And when you follow a process like Dr. Ayaz has set up from the school down south, which will remain unnamed, unless they lose to Michigan in the most important game of the year, and then somehow Ryan Day keeps his job because he wins a national championship. Okay, we're so happy he won the national championship. But enough about my football things that I have with Ohio State. He's a brilliant scholar, and you're going to hear from him later on. But when you have that type of talent, who decides it's important to study a community that often doesn't feel that they're worth studying, it lifts them up. And when people who sometimes have biases against that community, who do not come from that community, but realize how special and unique they are, and then see some of the same things in their own family, it lifts them up. And when you have a society that sometimes doesn't value numbers and expertise because they have been treaded on by people who are experts and have been told that their lives and their attitudes are not as important as those individuals' lives, but you take that and you give as a gift and you wrap it in a process that has compassion and care, like a beautiful stew that your mother makes. You know the food is better at your mom's house if your mom can cook. And my mom can cook. I know when my mom makes the food. I love my wife. She's not here right now. And this shall not be recorded. Thank you, Sahela. But my mom's food just has an affection in it. This research has love in it. You took one of the top experts in their field, and he could be doing anything, and he studied this community. And this community loves this region because this region loves us. And we love it even when it doesn't love us back, on both sides. And imagine if this little, small ripple of water can spread across our society. Muslims in Michigan have unique health attributes that should be studied. And what you're going to find out is that they have some of the same problems everybody else does, but they also have unique problems. And if we can solve those unique problems, we can take that approach and apply it everywhere else. And if people who have the talent of our scholar from Ohio State University can put their time and effort in, and if a 22-year-old institution, a 24-year-old institution that's got a good reputation, and Petra, leading the communications effort, can put that kind of effort into it, well, what does that say about the rest of us? It means that our diversity matters, but we have to love each other through the data. We have to care about each other in ways that are authentic and real. And when we solve problems for people who don't look and pray like us, we get to solve the problems for ourselves because they can look at us in ways that we can appreciate. And suddenly this word diversity, which has become a struggle, becomes something so valuable. So I hope you take some time to appreciate what Huda Clinic is contributing to this, but I really want you to take some time and realize the story, the data you're going to hear in this presentation is also a reflection of your own life. And when you solve their problems, they'll help you solve your problems, and this ripple can become a waterfall. Thank you.
Tall people. Thank you, Dr. Hamzawi. This was recorded, by the way, and I'm texting your wife in a minute. No, thank you for being here. I want to invite my colleague, Aram Akramallah, who will introduce our primary investigator, Dr. Iyaz Haider. But I want to make sure that you understand ISPU, as I mentioned, is a very small organization in terms of staffing. We have 14 full-time staff, 2 that are doing focusing on the research. So there's no way for us to do all of it. And that's why we work and we rely on the experts, literally the top experts in their fields. And we bring them to make sure that our community is studied properly with compassion and with care, because we understand there's a lot of risk in doing that. And that work, managing people outside of the organization, making sure that everything is done properly in a very rigorous way, that no one can poke holes at it. And I mean no one. And if questions come up, we not only have answers, but we can comfortably defend them. And when we find a limitation to the work that we do, that we are transparent and honest. And that's what ISPU does. And you'll see that in today's project. We faced limitation during the studying. We didn't just keep going. We regrouped and we rethought it, and we reshifted what we're talking about. The person who does that every single day from the beginning of the research project until it's published and then it's moved on to me is my colleague Aram, who's our senior research project manager. She worked with all of our research team, both internally and externally, but she also, in her own capacity, she's served as the co-author of the American Muslim Poll report, have authored several of the secondary analyses on that project, and previously she worked at Child Trends as a research analyst on both quantitative and qualitative research studies on topics related to child and family well-being. Aram, please.
Thank you, Petra. A little bit medium person here. Assalamu alaikum. It's really an honor for me to be here tonight. I'm really happy and honored to introduce the research team. So I've been a part of this project since its inception. The fall, I looked back at my first email with Dr. Hyder, fall of 2022. So we've been working as a team for the past 2.5 years. And as Petra mentioned, I served as project manager on this study. This team, my role was to kind of ensure we're meeting all our deliverables, staying within timeline, following up on next steps. But this team really made my job easy. But more important than that, what I observed in this team is a deep commitment to Muslim communities in Southeast Michigan. And I've continuously been in awe of the team that I've had the pleasure of working with. They have worked to ensure that this study truly honors the experiences of Muslims in Southeast Michigan. So ISPU, as Petra mentioned, was funded by the Robert Wood Johnson Foundation for this project as part of their Community Research for Health Equity programs. So this program supports community-led research to address local healthcare system issues of importance to marginalized populations. So under the leadership of our primary investigator, Dr. Ayaz Hyder, our team took this charge of community-led research very seriously. And one important step that we took to ensure that we were doing this correctly was to hire research assistants from the community itself. So our research assistants, Mohammed Muntakim, who you'll hear from today, and Zainab Khatu, are young adults from the community, interns at Huda Clinic. And so they joined the project team, fulfilled their duties as research assistants, but they brought something else to the team that myself, not being from this community, I'm from Maryland, and Dr. Hyder, who I guess I'll say is from down south now. We're not from Michigan. So what Zainab and Mohammed brought to this project was really their whole selves, their experiences, their context, their stories, their connections. And so they really played a really vital role and made the project stronger and informed the work with their own experiences. Our primary investigator, Dr. Hyder, brings substantive and methodological expertise to this project. But he also brings passion, compassion, patience, and commitment to using his expertise to serve and benefit Muslim communities. This is a bio I just made up, not made up, but what I observed through those 2.5 years that I've had the pleasure of working beside him. He's very good at listening, and I think that serves you very well as someone doing community-led research. So I'll go ahead and read his bio now, but I wanted to make sure I shared those personal observations that I had throughout this project. Dr. Hyder is an assistant professor in the College of Public Health and core faculty in the Translational Data Analytics Institute at The Ohio State University. He received his PhD in modeling pandemics and health disparities at McGill University and completed postdoctoral training at Yale and at the University of Toronto. He combines modeling and data analytics with community engagement methods to conduct research in the areas of birth and infant outcomes, opioid addiction, and food insecurity. Please help me in welcoming Dr. Hyder to share this research.
Bismillah ar-Rahman ar-Rahim. As-salatu was-salam ala Rasulullah sallallahu alayhi wa alihi wa sallam. We're going to do a little game here. 4-letter words only, okay? So if I say RW, you say JF, right? So RW. All right. IS. OH. See, I got you. Okay. All right. So, well, some of you said it, so it works. All right. Well, thank you all for being here from the bottom of my heart. As I was thinking about how to kick this off, I was reminded of an encounter about 13, 14 years ago. So there's a verse in the Quran that says, God does not place a burden on a soul that it cannot bear. And I think that applies to communities as well. So it's not a coincidence that Abdul al-Sayyid wrote the book called System Science and Population Health. It's not a coincidence that I ran into him 13 years ago at an epidemiology conference and got to know this field and this work. So we are here it's not a coincidence that we have these methods. So Tracy talked about, what is the problem? What are the problems? Dr. Hamzawi talked about, why are we trying to solve these problems? So hopefully what I'm going to try to do is tell you how, give you an idea of how we're solving these problems. And I want to introduce this first concept of a system. So this one right here, this right here, is how I explained it to my 8-year-old. She asked me, Baba, why are you going to this conference to present? What are you going to talk about? And I said, well, I'm going to talk about how we can solve one big problem by solving several smaller problems, right? So a more formal definition of a system is a set of things, people, cells, molecules interconnected in a way that they produce their own pattern or behavior over time. So systems thinking, right? So if you understand what a system is, then a systems thinking is a way you think about solving problems in a system, right? And so it's a way of thinking that involves understanding the overall behavior of a system by examining the interdependencies of its parts. So we apply this to access to healthcare. In the literature, there are about 8 or 9 different definitions of what the word accessibility means. It doesn't just mean, can I get there? It also means, do I have the means to get there? But it also means, are those means to get there actually working? So it's not like, do I have a car to get to this place? No, is my car actually working? Or do I have the money to put the gas in the car? Or if I get there, will that place be open? Or when I get there, will they accept my insurance? Or when I get there, will I be served by someone who treats me with dignity? Right? All of those things come under this concept of accessibility. So that's what access to healthcare is trying to get at. The purpose of this work and the study objectives are in this little pamphlet that you have, so I'm not going to spend too much time on it. But our goal here was to empower Muslims in the Southeast Michigan area with some of the knowledge and tools to advocate. And so what are those knowledge and tools? I'm going to spend mainly time talking about what those knowledge and tools were rather than how we created them. You want to read the methodology, there's lots of pages of words that you can read, and that's great. But I want to move on to some of the recommendations. So I'm going to move through the next couple of slides fairly quickly. Those of you who are researchers and want to ask me questions afterwards, I'm here. We can talk about it over coffee. But I want to try to get into the recommendations because I really want to hear from the panelists who are up here because this is really now about you and your community taking this work and doing something with it. So the first objective was to conduct these workshops, which I'll talk about. Second was to develop accessible communication tools for organizations and communities, like all of you here. And the last objective is to organize a forum, which we're doing right now. So check, check, check. The methodology that we use is called community-based system dynamics. I put this graphic up here. This is 2025 data from the county health rankings. I've gotten to know these counties really well now. I know all the Ohio counties, but Michigan, I just need to know these four. So this is the average life expectancy in the county, right? In the county, this is the average life expectancy. Look at Wayne and Washtenaw County. That gap of about 7 years or so, imagine what you could do with 7 Ramadans under your belt. People don't get to live that long on average. Imagine what you could do with 7 Laylatul Qadrs, the night of power in the month of Ramadan. Imagine what you would get if you had those extra 7 years, right? So this is why we study these complex problems, because we're trying to figure out not just why these disparities exist, but what can we do about them? Like I said earlier on, God does not place a burden on a soul that it cannot bear. So Allah subhanahu wa ta'ala has given us the tools, the methods to figure this out, right? We wouldn't have these disparities if we didn't have a way to solve these problems. So the participants that we recruited for this study were group model building workshop participants. Some of them are here in this room. They came from diverse backgrounds: education, healthcare, mental health, medical education, and public health. You need all of these different people to come together to solve complex problems. Nothing against dermatologists, but you had a bunch of dermatologists in one room, you wouldn't solve this problem. Nothing against our religious leaders, but if you had a group of imams in a room, you wouldn't solve this problem. You put all the social workers in the room, my wife is a social worker, they wouldn't be able to solve this problem either. You need the imams, you need the social workers, you need the dermatologists, you need the public health people. You need all of them to solve this problem. So we brought these different diverse perspectives together. The core modeling team, as you've heard, is something like the local steering committee, right? So this is in the Black Muslim community. That's why the title of this report was changed from access to healthcare among Muslims in Southeast Michigan to access to healthcare among Arab American and South Asian Muslims in Southeast Michigan. There's a reason we wanted this to be true. The title needs to reflect who these our recommendations are applicable to. Now, they might be applicable to other communities, but we don't know because we didn't ask the community. So we're not going to just make stuff up, right? That's not being fair. We did have 2 African Americans who were part of the study. One was a workshop participant, one was an interviewee. And we also had lack of representation from social service agencies and patients. So we didn't have any patient advocacy groups who were part of this work. If you think about the moment that we're in right now, recently one of the projects that I was on with community health workers, it got slashed. It was a statewide community health worker training and other kinds of demonstration project, and it was from the CDC, and it got slashed. So there's a moment that we're in right now, and if things are busy now, they were even busier earlier on for many of our social service agencies. We also had limited engagement with non-English speaking community members. So these are some of the limitations that we want to be upfront about. In terms of what we did, so I'm going to talk about the problem statement. So the problem statement that we looked at, which was developed by the workshop participants. So there's people in this room who developed this problem statement. I didn't fly in and parachute into Dearborn and be like, hey guys, this is what we got to solve. I didn't do that. This was a problem statement that was developed by the community. It says, which factors affect access to healthcare experienced by Muslim communities in Southeast Michigan? Now, I know it's a little hard to see, but at the bottom, there's this progression of problem statement, key stakeholders. So we had key stakeholders who were identified. Some of you may see your names on this or your organizations that you belong to. So I'm going to explain this graph. So this is the graph that we drew on the wall, right? We had permission from the hotel to do this to their wall. And then we had amazing graphic designers who developed this. So let me just quickly explain what this graph is. So imagine you have a level of agency or level of influence that the organizations or individuals have. Then there's a level of interest that they might have in addressing that problem statement, okay? Now, does everybody have the same level of interest in Yemeni coffee? No, some people hate coffee, some people love coffee, right? Right? People have different levels of interest in stuff. So, I'm from Ohio, I think I can get away with it. All right, may never be invited back here, so that's okay. I can try. So the level of power is the level of influence these different stakeholders have on that problem statement, on access to healthcare. So some people have very high power, some people have very low power. Some people have high interest, some people have low interest. Why is this graph important? This graph was important because who do we want to be? We want everybody to be high interest, high power, right? But those who are not, how do we increase their level of power? So those who are at this bottom over here, how do we increase their level of power to go up? And those who are with high power but low interest, how do we increase their level of interest in addressing this problem? If we're not honest with where people lie on this graph, we're going to start influencing people, and they don't need to be influenced. It's a waste of our resources. We don't need to lobby to certain groups because we've already determined they're high power, high interest. So why are we wasting our time? Why are we wasting our precious advocacy resources and dollars on that? So identifying where the power dynamics lie, where the levels of interest lie is really important. We also came up with several policy options. So there's about 26 of them here. Again, these are in the report, so I'm going to skip through this. But what they do is that these policy options span a lot of different areas. And what I really want to get to is explaining to you very quickly what a causal loop diagram is. So one way to think about a causal loop diagram is like a cause and effect, okay? So when you read these reports, you're going to see these weird diagrams, and there's a really complicated one. It looks like a bag of spaghetti. But this is complexity. This is how the world is. Like, I'm not going to simplify it, right? So we embrace that complexity, and we deal with it one causal loop at a time. So imagine the average level of education in a community. As the level of education increases in a community, unemployment rates would ideally go down. Agreed? Right? It's like a correlation, you can think of it. So that's represented by a negative relationship. As one thing goes up, another thing comes down, right? The red arrow. One thing goes up, other things come down. If the number of people who are insured or have insurance or ability to pay for care through their employer increases in a community, then the average education level might also increase, because guess what? They have health insurance. They're healthy. They might want to invest in their education. They might want to get that upskilling, or they might want to get that degree or that certificate, right? And so these loops identify these connections between the parts. Now, this is the really complicated one, and don't look at it. People like me and maybe Abdul back there and maybe some of you here live for this stuff, but most people don't. But this is what we can tear apart. This is what we can analyze. This is what we can rip apart to make sure that if we want to really address this problem of access to healthcare, we need to move all of these things, address all of these things at the same time. So imagine a car, okay? How fast do you think a car is going to go if only one wheel is working? Not very far. If two wheels are working, go a little farther. If four wheels of a car are working, it's going to go really, really fast. So in other words, if we address only the social determinants of health, which are the non-medical factors that affect our health, so the environment, the bias, the stigma that we might face, the cultural issues that we might face. If we only address the social determinants of health, guess what? We're going to make progress in that. But if we don't address racism and discrimination, and if we don't address public health prevention and healthcare factors, we're not going to get very far. But let's say someone says, well, we're only going to address racism and discrimination. Great. You've addressed racism and discrimination. But we didn't address the social determinants of health. We didn't address healthcare factors. Then what? We're going to be stuck. So I'm going to move on to these feedback loops because these were the three main ones that we came up with, and we're hoping that these are the ones that are addressed through these recommendations. Some of the key insights is that there are multiple pathways to address these outcomes, and it's insufficient for key stakeholders to only address one of these loops, right? So if we only address one of these things, we're not going to get very far. I'm going to quickly talk about the community leader interviews and the insights that we got from them, because they validated many of our key insights, but they also added things that are going to show up in the recommendations. So the recommendations. The first recommendation has to do with what I'm saying, access, affordability, and trust in the healthcare system. I'm putting a greater focus on this, not to minimize that religious accommodations like halal food and gender concordance care in the healthcare are bad. They're needed, right? And a lot of research and work has gone into addressing those things. But in addition to that, we need to address affordability. We need to address trust in the healthcare system. We need to address accessibility as well now, in addition to those other things. The second recommendation was design and implement prevention strategies that prioritize demographics, immigration experience, and socioeconomic makeup of neighborhoods. One thing you'll notice, and we talked to different people about this, neighborhoods are arbitrary. City administrative boundaries and county administrative boundaries are arbitrary. So if we focus on the people and their experience, we are able to solve problems realistically and holistically, as opposed to, I have jurisdiction in this, so I'm only going to work in this. You know, I know we have public health people and city people and others in this room, and I worked with them to understand the challenges of doing that. But what this recommendation is saying is that create partnerships that cut across neighborhood and administrative boundaries in order to solve these problems. Forget about jurisdiction. I know it's tied to funding sometimes, but we need to overcome and change the systems in which, if we're really going to solve these problems. Address hard-to-reach and minoritized population. What this one is really trying to get at is we need different approaches to address different populations. So one of the things we found is, while there are, now I'm going to compare to Columbus, we don't have any Muslim leaders in public health or healthcare in Columbus. Over here, I see them in this room everywhere. So, which is great. So what does that mean practically? What it practically means is that in a place like Columbus, we have to work on health literacy. Whereas in a place like Dearborn, where the Muslim community is about, I would say, 20 years ahead of Columbus, the work is, yes, on health literacy, but it's also on health diplomacy. It's also on not just what is said and whether it's understood and whether it's in different languages or not, but it's more important than ever now, who is saying it? Where are they saying it? In what events are they speaking? With what emphasis are they saying things, right? So there's a different emphasis now in those hard-to-reach populations. The recommendation number 4 was increase the number of Muslim community health workers. Go talk to Tracy. She'll evangelize that to death. Holistically address social determinants of health. Here I want to point out that one of the things that I'm working on in Columbus is the community information exchange. This is essentially the technology for care coordination. To holistically address social determinants of health, the recommendation is to encourage working with organizations and initiatives like the CIE, because they are trying to address problems that exist between nonprofits and also between nonprofits and government entities and healthcare systems and the social care system and the continuum of care and the free clinics. They're working across all these systems. And so it's really important that the Muslim community and our institutions become part of that work. The last recommendation, and then I'll be quiet, is to build bridges that are intentional, right? That are institutional bridges that are going to last for a very long time. Now, when I was a teenager, I heard a talk at our mosque by Sheikh Abdullah bin Baya. He's an international scholar. And he said, one of the reasons and he's not from here, right? So just kind of keep that in mind. He said one of the reasons Muslims should be able to immigrate to a country like the US is because they can build institutions. Institution building is part of it. So here what we're talking about in building bridges is institutions that are going to last, institutions that take a systems approach and are going to be sustainable over the long term. And a great example of this is the recent opening of the My Wellness Clinic. I was at the opening ceremony of that. Danish, he just texted me that he couldn't be here. He really wanted to be here. But listening to the people who were up there talking, that took a systems approach, even if people didn't realize they were taking a systems approach. They were doing it. They were doing the work. And so I think we are in a unique position to apply these approaches because, especially in a place like Dearborn or Southeast Michigan, other communities do not have the resources or the capacity or the willingness to do this kind of work. You do over here. And I think there's only like a handful of communities I can count on my hands that can do this kind of work. So if we want to solve complex challenges, let's call them complex challenges, and let's apply approaches that are not too simplistic, but that are achievable and doable. And this is an example of, I think, that it is possible. So thank you all for listening, and I hope that you all have a great time for the rest of the time. Thank you.
Thank you, Dr. Riaz. And my apologies to every speaker that I'm interrupting today and kind of rushing them. As you could see, there's a lot of amazing content and talent in the room, and we could, if we had more time, we'd go a little bit deeper. But for the sake of time, I want to invite our panelists to join us up here. So this is one of ISPU's way of trying to make things as easy and as accessible as possible, but also show what's already being done that can be replicated. As we know, this is a very small community. By this I mean the American Muslim community is a small community with limited resources and many, many challenges. So we do not have time to waste. We do not have additional resources to waste. So for the sake of that conversation, we want to make sure to bring people who are already doing this work here on the ground to talk to us about what these reports mean to them, what's already being done, and how can we move it, as Dr. Iaz mentioned, to the next level, addressing this issue from a systemic approach. And even though this specific study had limitation, in design thinking, they talk about if you design something to meet the needs of people on both sides. So for example, if you design a telephone that could be used by a 5-year-old and someone in their 80s, guess what? Everyone in between could use it. So we don't need to focus on the middle of the curve. We could focus on the two ends and hopefully catch as many people as possible in our way. So please help me welcome Dr. Ali. A lot of our speakers do not need full introductions. You all know them. They're doing amazing work, but I'm just going to read very short bios of theirs just to see the talent that we have here. Dr. Ali Abu Zaid is the City of Dearborn Chief Public Health Officer, founding director of the Dearborn Department of Public Health, which I just learned not only is Dearborn the second city in the state of Michigan to have a public health, but they actually did it voluntarily. So yay, Dearborn. That was launched in 2022. He's a Dearborn native with many experiences both locally, nationally, and DC, addressing many challenges, everything from homelessness to health in rural and tribal America, cancer prevention and control, global refugee crisis, and so many other things. And he's going to talk to us about some of the programs that are being done here in the city of Dearborn. He's also a 3-time graduate of the University of Michigan. Sorry. Just gonna, those who are local, they know what I'm talking about right now. Mohammed Muntakam, he's also was an RA for this project. He's a graduate. He graduated with his Bachelor of Science in Public Health from Wayne State University, also sorry, and is currently pursuing Master's in Business Administration at Mike School of Business. Mohammed is a clinical intern at the Huda Clinic, which is the largest, free-run health clinic in the state of Michigan. He served as a board trustee at the Skillman Foundation, its youngest board member in the History Foundation. And as mentioned, he served as a research intern for this project, research assistant, I'm sorry. Also joining us is Sabria Mills, who's a certified behavioral therapist and the host of the Dope Muslim Women podcast. She's a coach, a public speaker. I'm not biased at all today. A coach, a public speaker who specializes in helping her clients overcome heartbreaks and negative behavior patterns so that they can once again live purposeful and God-conscious lives. After spending nearly 2 decades working to address the needs of individuals living with physical and mental and emotional challenges in Islamic educational environment, Sabria continues to advocate for marginalized voices through her platform. Her work on the platform aims to amplify the voices and experience of Black American Muslims while at the same time working to support the needs of marginalized communities through her work with heartbreak, healing, recovery, communal belonging, and ancestral trauma. The next speaker we also have is Carrie Harbour. Sorry if I'm butchering the last name. She is the Chief Public Health at Oakland County Health and Human Services. Remember, the study covered 4 counties, not just Wayne County, not just Dearborn. She's a public health professional with expertise in community health assessment, strategy planning, health equity, continuous quality improvement, customer service, grant writing, research, program evaluation, and public health policy analysis. She holds an MA in public policy and political science. And then finally, we have, if you look at that graph that Dr. Iyas showed you with high interest or interest in power, all the way on the far right side of that graph is a name that we insisted need to be here for this report, is actually Dr. Abdul Sayed, identified by the study participants as the guy who needs to fix everything. So thank God he is hopefully aiming for a higher office. Dr. Abdul Sayed is a physician, optometrologist, and public servant. His public health service focuses on health Equity, Resiliency, and Environmental Justice. He's the host of America Dissected, a podcast by Crooked Media, where every week he invites experts to talk about, healthcare, public health, healthcare, in policy. He's a published author. We all know him. He's doing so much amazing work, both here locally and nationally. Some of his books: Healing Politics, A Doctor's Journey into the Heart of Our Political Epidemic, and Medicare for All, a Citizen's Guide. And a lot of other things that he does. He was as of last week, the former director of Wayne County's Health and Human Services Department. And I know he says in the article he will announce in a couple of weeks, but we could just decide today that he is announcing, We've made a decision for him. So please help me welcome our panelists over here to help us make sense of this report. So thank you all for joining us. As we take this report from, theory, and here's what we did, and here's how the community studied, let's jump right in. I'll start with you, Dr. Abu Said. He is going to have to leave a little bit early because he's jumping from one event to another, so we appreciate his time. But you do work both at the local and the national level. Connect the dots for us. What is this, Muslim health study about the American Muslim community in Southeast Michigan, looking at, systemic approach? What does that mean for this community, but also what does it mean for the national work that we are, or the country need to be doing for our public health system?
All right, Jazakumullah khair. First, I want to say that Dr. Haidar and I met at an epidemiology conference, would have been like 15 years ago at this point. And I generally agree with him on everything except for The Ohio State University. I really don't know why you need a definite article. It can be an Ohio State University. Anyway, so I'm grateful to you for leading this work, and grateful to ISPU for supporting it, and grateful to everybody here. I see some familiar faces and folks who have real power and certainly obviously demonstrated interest here. I want to just step back because I think it's really important when you read a report like this to appreciate what it's not saying. And what it's not saying is that there's any one silver bullet, right? And in the whole argument behind systems thinking, right? Before I ever wrote about Medicare for All or anything else, I wrote this textbook with a colleague of mine. We actually edited it, called System Science and Population Health, which nobody's ever read. There's 10 people except for Dr. Haidar. And it seems like they're actually reading valuable things at Ohio State, which is amazing. But all of it is to say is that there are no silver bullets. If you want to understand how to solve a problem, it's not really about any single solution. It's about how these solutions hook together in ways that make them greater than the sum of their parts, right? And why I say that is because when you think about solutions, we all want to say that this is going to be the one. If only we did X. If only we did Y. All we need is Z. You hear that all the time, right? And actually, the whole argument here is actually none of those things. What we need is a set of solutions working in ways that target some of the key features that either disrupt, right, harmful feedback loops or promote positive feedback loops. That's what we need to do. And you mentioned work at the national and the local level. And the other part of the conversation that I think is really important is because we tend to focus on silver bullets, right, we tend to forget the context. So even if you had a silver bullet and you fired the silver bullet in the dark, the chances that the silver bullet is going to hit what it's supposed to hit is very low. But when you have light and the scope, I hate the silver bullet because it's very, very dark, very, very violent. But if you fire it in the light at a very big target, the silver bullet might have a better impact. But we forget the context within which any of our bullets fire, right? And so all of it is to say that a lot of the conversation nationally tends to shape what it is that we can do locally and how it is we engage. I got into epidemiology and public health, frankly, based on a study that was written just after 9/11. And what the study looked at was the risk of preterm birth and low birth weight among Arab-named mothers in the 6 months following 9/11 as compared to the same 6-month period in the year before. And we sought to replicate that study in Michigan. And what the study found, based in California, was that after 9/11, there was a higher risk of preterm birth and low birth weight among Arab named moms. And the argument being is that the social context had changed. Being Arab American before 9/11 meant one thing, and after 9/11 meant a very different thing, right? Context had changed. And then we reproduced it in Michigan and found no effect. Now, why would that be? Because we were reproducing it in a different context. Because Arab Americans in Michigan, particularly after 9/11, tended to be nestled in Arab American communities. So your social experience as an Arab named person was less likely to be as challenging from a discrimination standpoint because you were less likely to be engaged with people who would be likely to discriminate against you, right? And what I'm showing here is time context and space context really matter. So to your question, Petra, which I really appreciated, is how do we think about that national versus the local conversation? And the thing I want us to remember is that Arab Americans in Michigan are unique. Right? We have a categorically different community, and Dr. Haidar mentioned it a bunch of times, because the context is different. Because if you are an Arab American or a South Asian American or a Muslim American in Michigan, chances are your social milieu and your experience of being Arab, South Asian, or Muslim or Muslim is completely different, right? Like before, we were doing like suhoor festivals in Ramadan before it was cool. Now everybody's got their suhoor festival, and I still think ours is the best, right? But the point is that a lot of these innovations come from here. And so as we think about that national to local, I think it's really important both to ask questions about what actually applies and what doesn't, right? And then second, to remember that the things that we do here are contingent on understanding our own social space and interaction set. And I just want to give you one last example, and I'll hand it off. Think about the conversation about vaccines and vaccine hesitancy, right? Oftentimes, if you were to look at demographics in the Arab, South Asian, and or Muslim communities, right, you would expect a whole lot of vaccine hesitancy, right? Traditionally, though, if you look at particularly Arab cultures and also many South Asian cultures, there is a shot for mentality, right? So like people will just go to the doctor and be like, listen, dude didn't give me a shot. Like, what did I even go there for, right? So it's like not even vaccine hesitancy. It's like vaccine love. Like vaccine, like philia, right? In which case, when there's a vaccine, people are gonna take it, yeah? But not all vaccines. Why? Think about Gardasil. That's a vaccine for a particular disease that has a level of social stigma that is uniquely stigmatized based on particular cultural beliefs, norms, and values, right? And so I think it's important for us, right, when you think about funding that's available, for example, around vaccine hesitancy, a lot of us talk about making sure that you're culturally relevant, et cetera. And they're like, yes, we'll translate it into Arabic. And you're like, this not all Muslims speak Arabic, right? And they're like, okay, we'll translate it into whatever language you want. You're like, that's not going to change the fact that you actually need a different message, right? And that message isn't going to be one that is specifically tailored around what we usually think of, which is like racism, right, or discrimination, but it may need to appeal to, right, particular norms, mores, and values, and also recognize that there's going to be differentiation between them. And so it's really important as we translate that we always think about the context. And I thought that was the part here that was so rich and so deep in this work, is that when none of us exist as mountains, we all exist in context, and our context is one another, and that context changes the way that we think about the interventions that are necessary. And so as we build from here, the joy and excitement that I have is that I see the builders of the future of health. Like they're sitting here, they're sitting out here. And so we need to start thinking about, right, from elsewhere where there's funding, which is usually what we do, right? We need to be asking what needs to be built anew. And how do we target those opportunities to disrupt feedback loops that are dangerous and promote feedback loops that are virtuous? I'll leave it there. Jazakumullah khair.
Thank you so much. That's actually a perfect segue to my question to Ali. We don't need just Arabic translation for some of the work that needs to be done. We need a whole different approach. So my question to you as the director of the Dearborn Public Health Department, and Dearborn is a whole different universe for those who did not grow up in Dearborn like myself. It's a different universe that we love so much, but it does need its own messaging and its own approach to addressing issues. Can you talk to us a little bit about your department? Pick one issue share what is the work that has been done, the issue if it's connected just to the local community or if it has national implication as well, and success or not.
Thank you. It's so good to be here. I can already tell you I'm not going to stick to one. I have no idea what I'm about to say, but let's see what happens. I'll try to bring it all together into something coherent. But I'm really grateful to be here. I'm really grateful to Dr. Haidar for the study, Dr. Iltifat for the great work. I'm getting to know him more and more. My God. And then Dr. Petra, you honored me with the honorific doctor, and I'll honor you with it. I'm not a doctor. I've been getting that for the last 10 years. I did say that after a few years, I'm just going to stop correcting people. But since I'm amongst my kinfolk, I feel like I can say this year, God keeps sending me that sign, get the PhD kid, get the PhD. I chose very consciously not to get it. But I don't know, maybe I should get it. 3 years ago, actually, I was just mentioning this to Dr. Iltifat, we just celebrated our 3-year anniversary yesterday of establishing the Department of Public Health. Thank you. And at the time, we became just the second city with a health something. People don't like it when we say health department because that evokes certain things, and that's true. It does mean something according to the US code. It means something to the public health code. But we consciously chose to do something differently. And when I made that decision to come home, Dearborn is home, to launch this department, I actually made another decision before. I told the then mayor-elect, thanks but no thanks. I was at the NIH, I was in DC, loving my life. I think the mayor and this guy next to me were colluding because I had made up my mind, and then he was in DC, and we got together, and we ended up hanging out for like 2-3 hours, and he started off with, let me tell you why I think you should reconsider this, and why I think you should go home to launch this department. And so that happened. I thought about it, came home, the rest is history. So he deserves as much credit as anyone, and quite frankly, just because I'm sitting next to him, this never gets old. One of the biggest reasons why I got into public health is because I was researching how not to go to med school, how to pretend to my parents that I can do something that's more significant. And every time I was researching and looking for examples, and just someone who happened to be Muslim, who happened to be Arab American, but who was a brilliant person that was trailblazing and pioneering, it was always Abdurrahman As-Sayed. And so we're all grateful for him, and we're all excited for what's to come, especially in the coming weeks and months beyond. But launching this health department has been a true pain in the ass, to be honest with you. I love my work, don't always love my job. The work has been remarkable. I'm the sucker that took this job with no staff and no budget. 3 years later, we look a lot different. But when I say that we're a different kind of health department, you don't come to us for brick and mortar, vaccines, immunizations. You don't technically come to us for complaints about water quality, air quality. People do that, and we handle all of it. But we're doing what I like to call the health and all policies approach, which is quite simply just a weird way of saying, how do you collaborate across all city departments and sectors to make it so that everybody is thinking with a health lens? Historically, governments tend to think with an economic development lens, which is not something that government should be thinking about. Government, by definition, is about the public good, and so the private sector should be thinking about profits and losses. The government should never think about that. If the government thought about that, then we would never send the US Coast Guard to rescue someone off the coast of the Atlantic, because that costs a lot of money, and the return on that investment is not worthwhile. But that's not what the public sector does. We do things in the name of the public good. And so when launching this department, I tried my hardest to make that ethos the driving ethos, which is, I'm the least popular thing to be in America today. That is a believer in government. And I'm a believer in government not because government's great, not because government gets it right all the time, but I think back to a lot of the scholarship that I fall on, quite frankly. A lot of it tends to be black scholarship. And I really do rely on those who've come before us. And when W.E.B. Du Bois says, nations reel and stagger on their ways, they commit frightful wrongs, but they also do great and beautiful things, that's government. Our tax dollars fund really ugly, abhorrent things right now. They're doing it in Gaza, they're doing it in Yemen, they're doing it in other places, including domestically. But our tax dollars also do wonderful, beautiful things, like funding public science, like funding the National Institutes of Health, like making it so that each of us are benefiting from life-saving progress that's happening behind the scenes. And so I think the thing that I tried to do in Dearborn is make it so that that work is no longer behind the scenes. I am a weirdo. I think we're all weirdos, but I'm just willing to confess it. I rely on language a lot. I rely on my favorite writers and authors. When Toni Morrison accepted the Nobel Prize in '93, she started off her speech talking about the oppressive nature of language and how different sectors use language in different ways. In the academy and in science, we tend to use the calcified, proud, but calcified language of the academy. We also, in the last, especially preceding decades, tend to use the commodity-driven language of science. I think that what we all need to do is, while this brilliant, brilliant work by ISPU is producing data that's helping to advance science, we gotta do that. But we also gotta make sure that that data is salient to the public that we serve. And so my biggest critique of the academy and of science in general is basically what Dearborn Public Health tries to do, which is do good shit, but then make sure the public knows that you're doing that shit. Because if they don't know that, Petra, you started off this entire night talking about civic engagement. That's how you get people civically engaged, by letting them know what their government is doing for them. And so we've done that with overdose programming. We've done that with environmental health, making sure that industries in the south end of Dearborn, which happens to be the asthma epiburden of the state of Michigan, are protected from those industries, because it's not inevitable that certain people live there. It's that we've made historically zoning and policy and planning decisions that certain people's lives are just counted less. That's just the way that this works. Not because it's inevitable, but because people who are fallible made those decisions. And so that's the ethos of what we do in Dearborn. I know that's not neat, but it's all messy. It's all messy and chaotic, because I'm pretty messy and chaotic. But that's what we do in Dearborn, and it serves people closest to the pain, most importantly. So thank you all.
Thank you, Ali. Maybe we could go and get our doctorate together. I don't know. One day. I do also want to highlight on the Dearborn Health Department social media. They recently shared the success story of what they were able to do with overdosing, which, as we all know, and drug abuse, which we all know, this is not unique to Dearborn. This is not unique to Arab or Muslims. We're not immune to that problem either. This is a national crisis that everyone is trying to figure out. But here we have a department that's 3-year-old, has been able to apply culturally and religiously and community appropriate approaches that are also backed by science and experts. And we're able to reduce overdosing crisis in the city of Dearborn, which, again, that is a huge success story. Should not take it for granted, but that's something that can be shared, with other communities. So I want to make sure that I highlight that. Absolutely, yes. Mohammed, I'm gonna move next to you. Not only were you an RA or research assistant on this project for many years, but like many of us have personal connection to how this topic even, got your interest. As someone who myself care for 2 elderly parents, we have a child at home with lots of disabilities and rare genetic conditions. I spend way too much time in Michigan's health system and hospitals and with doctors, and I could write books on what needs to be addressed. But I don't have the time to do that because for those who are dealing with it on a personal level, we're stuck in the process of, I just need to make it to the next appointment, or I just need to get care for my family members. Is this going to be an issue if I raise this concern or this complaint, and so on and so forth? So with that, can you share the personal story that kind of motivated you to this project, of course, to the level of your comfort and the connection to the study and the data?
Assalamu alaikum. It's hard to follow up after them too, but I'll try to kind of share a story. As Petra mentioned, we all have a reason for doing the work we do. And for me to be engaged in this work, it kind of started about 4-ish years ago. Someone in my family, direct family, my grandmother, was trying to seek access to care at the moment. But unfortunately, she had been living in the country for less than 5 years at that time. So her services, in terms of insurance, were only limited to emergency care. And every door we kind of try to access seemed to close in front of her. And also the concern was her situation was in the oral cavity. So a general PCP or someone like that you couldn't really access. And every dentist that we tried to face had crazy upfront costs just to even see her, rather alone examine. So fall of 2021, we strolled through the doors of Huda Clinic, like most people do when they are looking for a place to go. And after being turned away from many places, for her especially being new in the country, she felt like this was another, dead end. But after one of the interns, as soon as we walked in, we explained the situation. They're like, if you're willing to wait, you can be seen today. And for her, that felt like a light. And fortunately, we were able to be seen. Dr. Niazi actually saw her directly. And then he pulled me aside and he said, look, I can take care of the extraction and the pain and the situation, but there's an underlying thing that needs to be taken care of in her oral cavity, and you need to visit this place to actually get this examined and looked at. And turned out, unfortunately, to be a verrucous carcinoma at the end of the day. And we were able to get her diagnosed and start a course of care that still she's under treatment. So may Allah preserve her. But for me, that was kind of the opening to Huda Clinic. So the very next cycle that came around, I decided to apply to be an intern. And then Tracy can allude to this. I probably had a shorter length of my beard coming into Huda Clinic in 2022. But for me, the reason I share Huda Clinic and that story is because every day when we see patients every weekend, when I see a new patient that comes into the clinic, the first question I kind of ask them, most of the times it's in Bangla, is what brings you here, or how did you hear about Huda Clinic? And every single patient has a different story. Whether they're coming to the country, they've been here for a few months, they don't know where to go to seek some treatment, or they've been on Medicaid for 10 years that's been cut in the last 3 months and they're rationing their medication for the past 2 weeks. They want something to be able to kind of maintain themselves. Every single patient has a different story. And for me, that's the meaning behind the work, is when I sit across the patient and hear their story first, it kind of brings you to be able to, serve them at a better lens. And most of the times it's stories from patients that are from the similar background from us. And that's what this research is about. For me to be engaged in this work, it came down to how do I enable myself to support the work that's focused on not only healthcare, but our specific community. And what this research does is takes all these stories and identifies the barriers within these stories and tries to come up with recommendations and solutions, as Dr. Haider mentioned, to possibly address these barriers that are limiting in every individual stories. So for me, this work's about all of us have a unique story, and this research tries to, on a larger lens, take these stories as a whole and address them as a collective community.
Thank you, Muhammad. And this is, it really highlights the importance of bringing our own experiences to this field and to a lot of other fields. Personal and communal experiences are not always, do not always need to be divorced or separated from those experiences. It add richness not only to identifying the problems, but also to identifying possible solutions. So I'm grateful for your experience and for you for sharing this work with us. Sabria. All right. I just love her podcast, by the way. So I found a reason to get her in here. Just kidding. Your background, behavioral health, certified behavioral health, you spend a lot of time working with individuals. ISPU, we try to capture as much of the experience of the diverse groups within the American Muslim community. As I mentioned, it's literally the most ethnically diverse faith community in this nation. And we're not always successful. And so when in spaces where we're not successful, we try to be authentic and honest and transparent about, okay, what went wrong? Why weren't we able to do that? And this is the story of this study. We tried really hard to recruit. And it wasn't the lack of interest or the lack of connection. There's always the first step, the second step, and then it never finalized. There's a lot of history and there's a lot of background for that. If you don't mind sharing with us, what are some of the limitations and the struggles to reach or doing this type of work within the African American community, not to make you the spokesperson, but based on your professional and personal experiences. And then if you see any application for addressing a system or looking at it from a system approach, what are some of the ways that we could move forward?
Thank you, Petra. Assalamu alaikum. Greetings to each and every one of you. First and foremost, I want to just thank you for the invitation. I want to thank each and every one of you for allowing me to be in your presence. For my esteemed panelists, thank you for allowing me to sit beside you. I'm honored to be here. I have a lot of notes and thoughts about this topic. It's quite heavy, and to be honest, it's quite emotional for me to think about health equity and the disparities in health care. I am a descendant of the transatlantic slave trade. My ancestors, which I'm very blessed, my family has been able to trace it back. My name is Sabria Mills. That is traced back to the Mills Plantation, so that is not actually my lineage, but it's traced back to the Mills Plantation in North Carolina. And my parents, God bless them, were born during a time, they were born in the city of Philadelphia, in the inner city, in a time of major racial strife. My father was forced into the draft in the Vietnam War and used kind of like a human shield. And both of them decided to be a part of Black liberation movements and the Black Panther Party, if you're familiar. So these are movements that happened 50s and the 60s and post the assassination of Al-Hajj Malik al-Shabazz, just to offset a lot of the things that were occurring. And then my parents found Islam, and they became Muslim, and they got married, and they had us, 8 of us. Alhamdulillah, alhamdulillah. But when we as Black people think about health studies, medical research and studies, we go back to our history, and it's a painful one. The history of us engaging in studies involve us being poked, prodded, deceived, and lied to. And that's just a reality. And to be honest with you, as my brothers and sisters, and to be honest, some of you may even be some of my medical doctors and my dermatologists, and those I engage all the time in community who I love and adore, and I hope you see me as your sister. But I want you to understand that this medical industry that you participate in was built off the backs of the exploitation of Black people in this country. Many of the research has been a result of some of that exploitation, excuse me. Most of us, we should know, as medical professionals of the syphilis study, the Tuskegee syphilis study that was done in deception, which deceived a large amount of African American men. This was one of the longest standing studies. It was done from 1932 to 1972, which engaged individuals that had the disease of syphilis, but deceived them, did not give them any medical treatment, and wanted to see how Black people do with this disease. In more recent times, in the 1990s, one of our most prestigious US universities actually did a study. They recruited African American boys, and they hypothesized that they wanted to hypothesize just about a genetic etiology of aggressive behavior. I work as a behavioral therapist, I work in a behavioral analytics, and most of my work, especially when I go in clinical studies or I work in the school system now, they want to always give me a slew of Black boys with quote unquote aggressive behavior. I just want to give you some details about this study, and it was noted for its unethical measures. They used, first of all, monetary incentives that convinced parents to enroll their children in the study, first and foremost. They exploited the social economic barriers that are already there and the needs and the desperation of the people who are already experiencing economic oppression. Those that engaged in the study, they withdrew them from all medications. They made them ingest, it was a monoamine, and forgive me, I'm not a medical doctor, but it was they gave them something that really actually increased their serotonin levels and actually to measure their aggressive behavior. They made them stay overnight without parents. They withheld water. They did hourly bodily withdrawals. And again, this was the engagement. This just happened. This is very recent. And this happened at a prestigious university. This is noted in some of our most notable scientific journals. And this is just to say, these are our medical studies. These are some of our medical studies. And a lot of it does, when it involves engaging the African-American community, the fear is that it's going to be wrapped up in deception, and it's wrapped up into what we perceive as mistrust. Because again, we have a historical implication of it, right? And so when we talk about the limitation and that barrier, honestly, the findings does not surprise me, right? And some of it does involve, I think, my brother here, I'm sorry, I missed your name, but he was speaking about the language. And I thought that was such a powerful point, because the language can be very oppressive. My husband, mashallah, he's a religious scholar in this community. And mashallah, he's also a translator, so he translates Arabic to English for some of the shuyukh that are in Yemen. And he engages a lot of the communities here, and we're on the west side of Detroit. So our community is very diverse, but we also have individuals who just, honestly, they come to take shahada, they still smell like marijuana, right? They're coming off of the alleyways and such. And my husband can't help it, mashallah, may Allah bless him, because I always say he's so intelligent. He's the most smart and most intelligent man I've ever met. But a lot of times he's just teaching, he's teaching from these sacred texts, and I'm like, honey, they don't understand what you're saying, right? Not because people are unintelligent, because there's a history of the systemic barriers with education and healthcare against a group of people for the benefit of another group of people. And we have to be aware of that and conscious of that in our work, right? And this is not to tell you a trauma story. Honestly, I call it my liberation story, because I know it's on the backs of our people that this country is even able to exist in the way that it's existing now. So I don't feel any shame with it. But the reality is that when we engage these studies and when we engage our communities, we have to be conscious of the history. Sometimes we have to review it. Sometimes our language has to change. When we talk about building bridges and building relationships, even in that language, there's sometimes in the way that we say, okay, I want to engage you, even in that, there's triggers, right? Because it has historical implications as it relates to the racism and the disparities that African Americans experience. So I really appreciate this study, and I really appreciate the work that ISPU does. And again, I really appreciate you, Petra. I've used ISPU, I told you this. I've used it for a lot of my research, a lot of my work that I've engaged. So I have a huge respect for the work. And I really appreciate this question, and for Dr. I'm really bad with names. The one who spoke and mentioned how you changed the name of the study. Yes, mashallah. I appreciate that. So we didn't get these participants, so we're actually going to change the name so that it's honest. May Allah bless you. May God bless you. May God bless your work. As it relates to these recommendations, mashallah, I think they're beautiful. And again, with the African American community or anyone that has experienced oppression, and we know what's happening in our brothers and sisters in Gaza, Philistine, and in Yemen, they're all our brothers and sisters in this struggle against oppression and genocide. And one of the things that these communities need is, again, safety. It's that primal need. After your need to survive, you need to feel safe. So if I'm thinking of engaging, and I think there's some mention of this in some of the recommendations, but it's like, how can I bring the element of safety to the table in my conversations around engagement with these communities? And what is safety for that community, right? A community that may not feel like they necessarily belong, a community that may not feel or may have been made to feel inferior for whatever reason, whatever those barriers are, whatever that propaganda has been, right? What is the element of safety? But the key thing is relationship building. It's these conversations we're having right here. It's the invitations that are extended. It's the invitations to the dinner tables and building these relationships, visiting communities, right? Visiting communities, even if it's not the most comfortable, right? go and if bring your study into communities, engage individuals, and as you build these relationships, inshallah, it can help. But again, people have to feel safe in order to engage. So I think that's the primary thing when it comes to the implementation of that.
Thank you so much, Sabria. I intentionally, not only because she brings fire to the house, but I really intentionally, made sure that we have her voice here, because I am in so many spaces where we talk about the Muslim experiences, but we don't intentionally focus on, are we representing all segments of the Muslim experiences? Are we just focused on our own community? There's nothing wrong with that. Nothing wrong with focusing on our community, but we need to be realistic about what we're talking about. And being here in southeast side of Michigan, where we have one of the most diverse yet most segregated communities, if we don't start with this conversation here at home and have the knowledge go both ways, then we're not doing justice to ourselves and to our community. So thank you for bringing that background. And again, as someone who interacts with the healthcare setting and seeing medical trauma firsthand, severe medical trauma, I could only imagine what those who've experienced it for a generation are thinking about when a random organization that says we were founded in Michigan, but you can't see a building here where you could visit because we work virtually, say, do you want to participate in a health study with us? And they're like, no, thank you. So with that, I want to wrap it up with Carrie. As the Chief Public Health at Oakland County. So we're stepping a little bit outside of Wayne County, but there's all of this intersection and connection between them. Tell us, based on what you've heard from the co-panelists, but also based on the work that you're doing in Oakland, one of the most populous and diverse counties, again, in the side of the state. I'm sure the challenge is not easy to address the needs of everyone. So how do we take the needs of the communities, the diverse, sometimes contradicting communities, into account and make sure that we're doing the best by everyone? What are some of the programs or some of the best practices that you've applied?
Hi, everybody. Thank you so much for having me here tonight. I especially, before I get started, want to acknowledge that I think I'm here on behalf of our Deputy County Executive, Medea Tarek, who couldn't be here, but she is so excited about this research and this study. So just to talk about some of the things that we're doing in Oakland County that is relevant to the report, or some of the things that my co-panelists have mentioned. I think I don't know, maybe this goes without saying, but we try to take, especially the team that I work with, an equity lens to everything that we do, and try to be, especially since COVID and beyond, very conscious of the fact that people have a strong distrust in government a lot of the time. So I think one of the most important things that we do is just develop strong partnerships with community partners. So starting in COVID, we did regular vaccine clinics with ACC. We work regularly with Access, and then they are members of a lot of different coalitions. We do a large community health assessment every 5 years, and they all play integral roles in that. So really helping us, instead of, again, just like translating things into Arabic, working with our community partners to help deliver that message and just work together to reach better into communities that might not want to engage with us otherwise. One of the things that I think was mentioned earlier, and that relates to, is we recently just launched a program called Oakland Connects. So that is, we've made an investment in hiring a large group of community health workers that are going to be working with residents to navigate, the complex healthcare social service system and addressing social determinants of health. So we have hired a coordinator and community health workers that are going to be on the ground working with people. And so we have hired people with backgrounds from immigrant communities, from Muslim communities. And so we're really excited. That's relatively new. And we're really excited that that has gotten off the ground and is going to continue to grow. And we've gotten funding to expand into different parts of the county, into working directly with some school districts. So I'm just very excited about that work and hoping we're starting small, kind of working with internally across our county departments and with some key partners, but do want to eventually build that into a full community information exchange model where there is like regular data back and forth with community partners. We know how our clients are kind of navigating through the system and really feel like that is going to be critical into just helping improve health outcomes for our diverse populations. We have made really strong attempts at hiring a diverse variety of community health workers. And then another investment that we've made that we're going to start working on is doing this comprehensive language assessment and language access plan to not just we're going to randomly pick these 3 languages to translate our materials into, but really looking at like what are the needs out there of people who speak languages other than English, and what are the best ways that we can meaningfully enter those communities, impact that work, things like that. And then I think areas that maybe I would like to see us grow or work in. We focused on working a lot with organizations that maybe work with the immigrant community or work with specific ethnic populations. I think maybe sometimes governments kind of hesitate to, or at least for Oakland County, we could do a bit more work growing in the faith communities. We had strong partnerships again during COVID with Black churches in Pontiac and Southfield, and we know how important faith leaders are to helping being a trusted resource and helping deliver messages and helping us reach into those communities, especially when there is mistrust of government. And so I would just really like to see us expand that work into other faith communities. If there's anybody here from Oakland County, you can hit me up and we can chat. So I think that's all I have for now.
All right. Thank you all so much. I know we are at time, but I do want to take maybe 1 or 2 questions from you all. Some of our panelists will be sticking around, or feel free to get in touch with myself, Aram, Nancy, Dr. Ayaz, if you have any specific questions. I also want to make sure that I don't forget to thank Dr. Tayyib, who was not only the recent board chair of Huda Clinic, but one of the founding members. And I know we've talked a lot about Huda Clinic. It is very important here locally, but it's also nationally, and he's, without him, Huda would not be around. So let me take 1 or 2 questions from the audience, and then we will wrap it up. All right, I see 2 hands, 1, 2.
Thank you so much for the event and for the panel. I have a question for you all. You're all doing really wonderful work, but we can't do that work if there isn't money. And I have to say this as a data analyst at the University of Michigan, where 24 grants have received a Stop and Work order recently. How are you navigating the current cuts and the current guidelines from agencies like National Science Foundation, where you can't say minorities anymore, you can't say cultural sensitivity? Yeah, so how are you guys navigating that to secure funding in these changing times?
It's a perfect timing for us to publish a report on Muslim health, right? Like, it's great. So how are we navigating the current climate and funding? Think about that. I'm going to take another question, and then we'll just answer them all at once.
Thank you for the questions. By the way, I see Dr. Tayyib here. When we worked with Brother Mitchell, I mean, actually, I was there when the foundation to relate for Huda Clinic. And the idea was, as the sister pointed out, a lot of us healthcare providers were Muslim, but we were disconnected from our patients. I was at Dearborn Hospital, I was a medical student at that time, and I could clearly see the disconnect. Like a lot of us, they were doing internships, a lot of them were attendings, but there was not a connection. They all went home, and the patients stayed there. So I think the Huda Clinic came about for that concept, and I really credit Dr. Faisal Hazi, who's actually in California now, and he was the first one who pointed that out to me, and actually a bunch of us realized that. And I hope Huda Clinic still continues that tradition and is that foundation. And I mean, unfortunately, I've not been involved with Huda Clinic quite a bit, but I know a lot of people in the community have. And I think that's where the dialogue needs to start. So that's where the real trust, I think, is. My question for you guys is, somebody had a map up there, that showed the ages of lifespan, what's in Washington versus Wayne.
The life expectancy.
Life expectancy, yeah.
So I would argue the worst of those counties is actually Macomb County. That's where the real disparity is. A lot of our Muslim community is landing there, and there's not a lot of infrastructure in the Macomb County. It has the biggest rural and urban community mix, but there's a big disparity. And there's a lot of politics involved in that county. The last 2 years I've worked in that county as a physician, and I started realizing how deep-rooted this is. If we are going to be successful in our communities, we will have, I would say, reach all the 4 counties.
Yes.
Recommendations you have are great, but who are you giving those to?
You all.
Yeah.
I'm out of here after. I'm just kidding.
So I would say all 4 counties. If the goal is to make sure everybody gets equal care, everybody in that county gets that. Because unfortunately, I don't think we have even a footprint in Macomb County.
I joke, but I'm not. So, you know, the invite list for this event was not random, just like any other event. ISPU does research. In my personal life, I do a lot of things. I have a lot of opinions. I say a lot of things that I don't do with ISPU just because we're a research organization and we have to stay nonpartisan, non-religious, a lot of things, right? We also do national research, meaning we're researching the American Muslim communities in 50 states, but also local communities. We only have 14 staff. What we do is we equip you all. When it comes to civic engagement, we did our research on the Muslim vote. We identified the policy priorities. We said, this is what the Muslim community said they want, who they want to vote for, what they're going to vote based on. I didn't go out there and said, you know, this is what we're going to do. I handed it over, myself and our team, to the organizations that are doing civic engagement work and said, this is what the Muslims said. Y'all do your work. This is what we're doing with this report. Yes, I will have meetings with some people. Please, if you can, help me. I would love your assistance to connect with the right people. Dr. Ayaz wants to meet with health officials and executives in the 4 counties. But after a certain period of time, I gotta move on to 10 more reports that are coming on different topics. So this is why you all are here, because you're either part of the healthcare system, you're an advocate, you're a social worker, you're somebody who cares. We shared with you what we're able to. We are more than happy to sit and have additional meeting and walk you through what it means, how you could use it, who you need to talk with about it, how you get to talk about them, where you could use the data in any letter or report. We could do all of that with you. But after that, it's on you all to utilize it and implement it and include it in your work. And this goes for literally anything. I know this sounds really mean, and I usually don't talk like that, but I genuinely mean it when I say ISPU is here to equip you, do the work that you already do. Suhaila.
I just want to share something. What ISPU is doing is unprecedented for someone like myself who's been facilitating trainings on our community to military, law enforcement, educators, institutions, I never had the opportunity to have the quality data that I needed. So when they're facilitating these conversations, it's incumbent upon us as leaders and people within these various agencies to be able to take those messages. Like I just came back from facilitating a training on Islamophobia, and all of my data comes from ISPU, so that this way when I'm talking to these county and city officials, these agencies and various organization leadership, I'm providing them with all the information that they need on our Muslim community nationally, and giving them an organization that they can go to find all the information they need, as opposed to going to Pew or others who may not have complete data on our community. So,
and to even go a little bit further, in order for different segments of the American society, not just American Muslims, to take ISPU's work seriously, we can't do advocacy. I can't go and meet with someone and say, I want this bill passed, even though as a Muslim person I do, but as a research organization, I have to
depend on
stay as much as I can unbiased. And so what I do is, you're having a meeting with health executives in Oakland County. You know, you want to convince them of something that you're doing, right? That this is the approach I want to take that's going to help our community. I could come with you, share the data and the research that we have that's applicable to that meeting. I could literally leave that room, and then you do your policy ask. And that's the approach that we do with a lot of different topics. And I'm happy to chat further. I do want to move on to the funding question because I also want to be respectful of your time.
Yeah, so I can talk somewhat about the funding issue. It's kind of been in the news. We have a new health officer. We've lost, a significant number of grants in the last week. So the landscape is kind of changing day by day, especially with the kind of court orders now. So we're trying to figure it out. On my team, I had a grant that for us to be the backbone organization for a regional health equity council that was focusing on racial and ethnic health disparities, looking to mitigate those from COVID to better prepare us for the next disease outbreak. That was unfortunately cut. Had to let one of my staff people, or at least tell her to temporarily pause working, that's been with us for 3 years now, which is just super disappointing. And that is work that, we were doing with a lot of strong community partners. We were able to finally, I've wanted to do more hear directly from residents, be able to compensate them for their time, be able to, value their life experience monetarily, and this was the funding that allowed us to do that, at least figure out the government bureaucracy of doing that process. And so unfortunately that has stopped right now, and kind of we're trying to, look ahead and make contingency plans. I've got some of the funding we lost were for like disease interventionist people, so they're no longer, again, at least for right now, able to work. So I've got several epidemiologists on my team who work in areas like opioid overdose, SUD surveillance, injury and violence surveillance, lead, EH issues, all very important things that we want to be able to track and monitor. And we know that if there is if God forbid, like there was a measles, a bigger measles outbreak or some other disease outbreak where they're going to have to step in and help with that. And then some of this other very important work isn't going to be able to focus on as much. And then I think you also kind of talked about like language and DEI, and that again is an ongoing conversation. We have a DI officer for the county. We're gonna keep doing what we're doing. there's been some individual applications. We were applying for to be a host site for a fellow, and so needed to talk about, like, do we need to tweak that language just to be able to have people here. I've been at Oakland County for like 13 years now, and the county voting demographics have definitely changed, and our administrations have changed. So I've been in that space of having to kind of talk around the work that we want to do, so we have experience with it. I just, personally, don't want to go back there.
Do you want to? I think it's such an important question, and I'm sorry that I don't have a satisfying response. I think the first thing that I'll say, and I can say this, I tend to get in trouble. Obviously, you all can probably sense that. I think the wannabe fascists want institutions to capitulate, and it is shameful that those institutions that should be the first line of defense against that fascism are the first to capitulate, including my alma mater at the University of Michigan. And so that kind of capitulation is so tragic, was not happening the first time, is happening now, and this is real. Funding is real, money is real. As fungible as it might be, it's real. I don't have a response for, we're dealing with the same thing that you're dealing with in Oakland County, but I think this is an opportunity for public health. And what I mean to say there is that I'm a public health person first, second, and last, even though all I want to do is read, write, and go to the beach. And public health started, its origin story was really radical. The idea is simple. Different people, based on who they are, where they were born, their skin color, their social circumstances, are at different risk for disease. That was a really radical idea when it was sort of originated. And public health, unfortunately, in the preceding centuries, has become much more of a technocratic field. Academics who are high on from above, just talking about their data and research. Again, I'm not saying that that's a problem. We need to contribute to the scientific academic canon, and also we need to do the other things. Communication. I'm not a one-trick pony, but this stuff is important. How do we communicate saliently? When I was at the NIH, we would have study sections and we would have different sessions, and the way that grants go out into the streets is that it first starts at behind the closed doors of NIH program officers, and I was a part of those conversations. I would tease all the time, what would it take for us as a body, a $47 billion institution body, the largest biomedical funder in human history, to make it so that every single prescription bottle in America says funded by you, the American taxpayer. That's what they do with the NHS in the UK, and obviously people would laugh at that, but that's actually what needs to start happening. So what does that look like for you in your day-to-day job? How do you make your work so that no one can ignore it? Because that is true. Every single prescription, every single therapy, if you've ever walked into a hospital or a primary care clinic, that was funded by all of us, the taxes that we pay. And so I try to keep that in mind every single day, which is the work is not the most important thing. It's not the only thing. We need to think about the doing good work and making sure that we're communicating about that work. One simple way to do that is, and this is what I tell my team all the time, if you're working on a study, and this is really for the academics and the scientists in the room, what would it look like for you to write a plain language op-ed in your local paper sharing the findings of that science? Think of that when you're starting the research, and then write that thing, and then publish it in the local paper, not in the Detroit Free Press or News. Find the Lansing paper, find whatever city in Ohio, Toledo, Pennsylvania. Write in the local paper in plain language what that looks like. I think that's where this opportunity lies for public health, is communicating better, more forcefully, and with a little bit more advocacy.
30 seconds. Okay.
As with our clinic, we will be facing a tsunami of problems. Medicaid is being gutted. A lot of grants are not being there. The stock market has crashed, so people who are donating are going to make decisions that may not be helpful for us. So we are going to think about how to resolve this, increase patient load, less money coming in. How do you resolve that? And that's going to be a significant problem for us. Thank you.
Of course. And I think just very quickly on the funding, because I know you've been very gracious with your time. I think one other thing, if I could add as a non-government person, non-researcher, but I think creativity, being very creative in the moment and thinking about, what can we do in the long term systemically, and also how do we make sure that we don't lose the progress that we already made, even if there are policies that are pushing us toward that direction. Dr. Ifal, want to add something to the funding question?
So first of all, the institution that sponsored this, ISPU, needs your support and funding. And so if you're interested, do that. But we also built ISP with almost nothing. We would do bake sales, literally. We did dinners, and we grew it from a budget. The first $40,000 we raised for the Detroit Moss study, we thought we were God's gift to humanity. And ended up taking a couple of $1 million to run this organization, but I'm very proud of where they are today. But all of you in this room, especially Dr. Jokaku, were instrumental when Dr. Jokaku started Huda Clinic. We were right there with him. What we did was we supported him as a dermatology group, and we took all the patients for free, but we couldn't always staff the clinic, but we took them on. My point being is that your work is so important, and if the work is that important, to Ali's point, you can actually talk about that and make plain language summaries. And this isn't pie-in-the-sky stuff. Sam Musallam is here. I'm at the Henry Ford Hospital part-time. We bring in millions of dollars of NIH funding for diseases that hit mostly Black Americans, Black American women especially, and it took us 10 years. I graduated from your institution, and nobody cared that I wanted to focus on that disease state. Now we're globally ranked. The top 2 global departments in productivity for Henry Ford Hospital focus on those population groups. And those elements of telling your story is so important. The other thing is, I'm not dope. I wish I was. I can't swear very well. I've tried, but I have an Indian mother, and I just think of her hitting me in the back of the head. But enough about my therapy. But one of the things that I think we have to also understand is that there must be conversations. For your institution, I work with a group called MGAGE. We supported a regent who's from the Republican Party. We talked to him about the fact that U of M's research is so important. You guys just got a deposit of $63 million out of your $72 million. Yes, $10 million was held back, but more than 3/4 is funded. There's a group of people coming from the America First movement who want to know this community. They have mapped out our data very well. They came here, I'm not sure if you heard, in November with a guy named Donald, and they spoke to everybody. Your research means something. ISPU means something. Working in Black American health means something. And when you share that story with people you think disagree with you, they may actually agree with you. And they may actually give you that money. And I'm not saying you shouldn't drop the S-bombs. Go ahead. It's helpful. But conversation is also helpful.
All right. Thank you all so much. Thank you for spending an extra time with us. I am going to move to close this session here. And like I said, we are around. Well, first of all, let's thank our panelists one more time. So what's next? I know we shared only 20 minutes of the report finding, and we kind of flew through it. But it is available on your table, and there are copies in the back. We also made a one-pager if you can't read the full report. But do start reading some of it, or read some of the other reports that we have published. The second part is to go to the gentleman's question. Share this. You're here for a reason. We handpicked most of you because of your connections and because of the spaces you're in. Now you're a messenger for this finding and for other work. This is meant to equip you to do the work that you're doing. Develop a plan for change, and collaborate with others. This is the big thing for our community right now. If we're not planning ahead, if we're not collaborating, if we're not thinking of, systems approach and preserving what we already have, we will be stuck in defense mode because we will always be in defense mode. But we need to carve out time to build our community and the communities around us. Without that, we're losing the next generation. Collaborate across sectors. This is going to take the social workers, the educators, the imams. I know we talked a little bit about religious spaces. There are so many of our religious communities and religious spaces that are doing phenomenal work on this topic that are not talked about enough, including ICD with mental health programming. There are so many others. I can't name all of them. But not only do we need to raise awareness of these programs, From where I sit at the national level or working with national communities, they look at this community here as all the stereotypes you could think about. We're the stereotypes. We're what we see on TV, right? We don't do enough to talk about the success in the building that we do in the state. And that's one way to counter the narratives that's painted about us. And by us, I mean everyone in this room. You know, I used to be here at the museum for 5 years before ISPU. I'm not joking when I say we used to get calls from, you know, national groups. Can we visit Dearborn Sharia zone? Can we, what is the dress code? Is it gonna be safe for me to be around Muslims? Like, we laugh, but that's the perception outside of this very safe, diverse community that we sometimes get stuck fighting with each other because we're comfortable enough to be in that space. Outside of the space, that's not the reality. Share the success that we have here. We have so much good that we have built. Share it, not only to count for the young Muslim Americans who are seeing what other people outside of the community see, which is the stereotypes, and they are internalizing Islamophobia. So that's my, you know, big sister message for all of us. What else is coming out of ISPU's work in terms of research? Like I said, this is one report out of 10 that are happening this year. So that's why we kind of move on and we give it to you all to do the next work. Couple other reports and smaller pieces are coming out, including one on American Muslim families, caregivers, young American Muslim families, child care, schooling, all of these topics that are important to us but nobody's talking about. So that's data that's coming out on caring for Asian adults. Like I mentioned, I'm one of those people, decisions around schooling. I know we are fortunate to talk about, you know, Islamic school, public school, all of that. We have the data on that coming out. Home ownerships, whole different conversation, y'all. Muslim converts. One piece that's coming out in a couple of months on Muslim converts. We have one piece coming out in May on the impact of popular media portrayal of American Muslims. Okay, now we all could say we know how the media portray American Muslims, right? We know that. But for the first time, ISPU will have a qualitative data that will show not only the percentages and the numbers that we could share with everyone in demand policy change, but we will show the connection between that depiction and policies that are impacting us. That's huge. And then not finally, but the biggest one coming out possibly September, October, as I mentioned, American Muslim Poll 2025. That's our nationally representative sample of American Muslims, American Jews, Catholics, Protestants, white evangelicals, non-affiliates, and the general public. All of their views on the direction of this country, politics, civic engagement, discrimination, and a whole lot of other policy priorities that we all care about. So stay tuned, get engaged, and this is where you could find us. And seriously reach out to me. I'm happy to share with you whatever we have that can empower and equip the work that you do. And lastly, if you want to entertain this and participate in this final small poll as a research organization, have we been effective in communicating what we need from you? So if you want to go to the website or text this number, and then I just have 3 simple questions to just get your feedback. And thank you all. Grab some food before you leave.